Welcome back to the deep dive. All right, today we're tackling a topic straight from the material you sent our way, uterine fibroids. Our mission is pretty straightforward. We're diving deep into this info you've shared, pulling out the absolute key high-yield knowledge, the stuff you really need for revision, making it stick.
Exactly. And, fibroids are incredibly common, much more than many people realize, but their impact varies hugely. So digging into this material is crucial to get clarity on the core concepts from what they are, right through to management. We're focusing on those key details that matter most.
Okay, let's unpack this then. First things first, what exactly are we talking about? Your notes define them pretty clearly. Non-cancerous growths in the uterus.
Right. Essentially, think benign tumors. They're bundles of smooth muscle cells and fibrous tissue growing in or on the uterine wall, and that non-cancerous part is absolutely key. They're benign. You'll also hear them called leiomyomas, or myomas, definitely terms to jot down.
Got it. And they're not just like one standard size or shape. The notes mention they vary a lot, different numbers, sizes, and crucially, different spots in the uterus.
Precisely. Size, number, location, it all varies. And where they grow is super important because that dictates the symptoms.
Okay, location matters. So your material highlights different types based on position. What are the main ones we need to know?
Yeah, understanding the classification is fundamental. There are three main types based on where they sit in the uterine wall. First, intramural. These are the most common type. They grow within the actual muscle wall of the uterus.
Okay, so right inside the muscle itself.
Exactly. Then you have submucosal fibroids. These develop just underneath the uterine lining, the endometrium. And here's a really high-yield point from your notes. These submucosal ones can sometimes bulge into the uterine cavity and even protrude down through the cervix.
Okay. That sounds like it could definitely cause issues.
It really can. They can significantly distort the cavity. And the third main type is subserosal. These grow on the outer surface of the uterus. Sometimes they're on a stalk, we call that pedunculated. And your notes mention these can get quite big, press on other organs, or even attach to things like the bowel or pop up in ligaments nearby.
Right, so quick recap for revision. Intramural, in the wall. Submucosal, under the lining, can bulge out. Subserosal on the outside can be stalked. Knowing that map is step one.
Absolutely. It's the groundwork for understanding the symptoms later on.
All right, let's shift from the what to the why and the who. Your notes say the exact cause isn't fully nailed down.
True, the precise trigger isn't known, but the notes list some major contributing factors. And what's really striking is the strong hormonal link. Estrogen and progesterone seem to be key players, which makes sense, right?
Yeah.
It explains why they're rare before puberty and tend to shrink after menopause. They're hormone dependent.
So hormones fuel their growth. What about genetics? Does that play a part?
Yes, definitely. The notes mention genetic factors, even specific gene mutations. And this ties into another really significant point highlighted in the material, a clear, strong association with women of Afro-Caribbean descent.
That association seems like a critical takeaway, which leads us naturally to risk factors. Who's more likely to develop them?
Well, age is a big one. Typically, women in their reproductive years, say 30 to 50, that's the peak time. That link to African or Afro-Caribbean ancestry is a major risk factor, as we said. And having a family history also increases your risk.
Your notes also list obesity, starting periods early menarche, and interestingly, never having given birth, nulliparity.
Correct. And hormonal imbalances fit the picture too, tying back to the cause. This list is basically a great memory aid for spotting patients who might be at higher risk.
So connecting this to the bigger picture,
Mm-hmm.
how common are they really? The epidemiology section in your notes gives some pretty eye-opening stats, especially for the UK.
Incredibly common. The notes quote figures like 20–40% prevalence during reproductive years, but the difference by ethnicity is stark.
Yeah, the numbers are quite something. Less common under 30, but then it really ramps up. Your notes say by age 50, it could be nearly 70% of white women and over 80% of black women.
Even by age 35, the figures mentioned are around 40% for white women and 60% for black women. It just underscores how prevalent they are and that disproportionate impact.
Those numbers really hit home. Makes you realize just how often you might encounter fibroids.
Exactly. So if they're this common, let's talk about what they actually do. Pathophysiology and clinical features. Remind us how they grow again.
So briefly, it's abnormal smooth muscle cell growth in the uterus, heavily influenced by estrogen. And remember those locations: intramural, submucosal, subserosal.
Okay, now the symptoms. What might someone actually experience?
This is where location and size really come into play. Although, interestingly, your notes point out that pelvic pain isn't always directly related to how big or numerous they are. The absolute high-yield symptoms to lock in are heavy or prolonged menstrual bleeding, that's menorrhagia and pelvic pain, or a feeling of pressure. And because they can grow, they can press on nearby organs, right? Your material mentions pressure effects.
Yes, definitely. Think bladder and bowel, primarily. Pressure on the bladder leads to needing to wee more often. That's frequency. Pressure on the rectum can cause constipation. Back pain is also possible.
The notes also mention infertility or recurrent miscarriages in some cases.
Yes, but this is a crucial distinction for revision. Your notes specifically clarify that it's mainly the submucous fibroids that are clearly linked to reduced fertility.
Because they distort the cavity where an embryo would implant.
Exactly, that makes sense.
And quite surprisingly, your notes say up to half of women with fibroids might have absolutely no symptoms.
That's right. Many are asymptomatic. And the heavy bleeding, the menorrhagia, can directly lead to iron deficiency anemia. That's a really common consequence.
There's also that rare but interesting detail you flag polycythemia from autonomous erythropoietin production. Definitely a niche fact for exams.
It is. And the notes also mention that those pedunculated submucosal ones, the stocky ones under the lining, can cause persistent bleeding between periods. On examination, you might feel an enlarged, irregular, firm uterus, usually non-tender, and you might see clinical signs of anemia.
Okay, so someone presents with these kinds of symptoms, heavy periods, pain, maybe you feel a mass. What else could it be? Your material lists quite a few differentials.
This raises a really important point. You absolutely have to think broadly with these symptoms. The notes list things like adenomyosis, that's where the uterine lining tissue grows into the muscle wall, also ovarian cysts or tumors, other issues with the uterine lining like endometrial polyps, or even, importantly, endometrial cancer.
And inflammatory conditions too, like chronic PID or a tubo-ovarian abscess, plus other pelvic masses, and always rule out pregnancy.
Don't forget the rare possibility of uterine sarcoma, a malignancy. This differential diagnosis section from your notes is vital. Always keep that broad perspective.
Right. So you suspect fibroids, you've thought about other causes. How do you confirm it? What investigations are key according to the notes?
Well, a pelvic exam is step one to feel the uterus, but imaging is really the cornerstone. Ultrasound is the standard first-line test.
And the notes specify transvaginal ultrasound, TVUS, as being more accurate usually than just an abdominal pelvic ultrasound.
Yes, it gives a clearer view. And for specifically looking at those submucous fibroids inside the cavity, the notes highlight saline infusion ultrasound sonohysterography as superior. That's a high-yield detail.
Good to know. MRI is also mentioned.
Yeah, MRI is highly sensitive and specific. It's often used if the ultrasound results are inconclusive or for detailed mapping before surgery.
What about other tests? Your notes list things like a pregnancy test, obviously, and a full blood count.
Absolutely. Pregnancy test is standard with abnormal bleeding. FBC is crucial to check for that iron deficiency anemia from heavy periods. And if abnormal bleeding is the main issue, especially to rule out malignancy in the lining, procedures like an endometrial biopsy, often using a Pipelle device or a hysteroscopy with biopsies, are really important.
So these tests help confirm the fibroids and crucially rule out those other conditions on the differential list.
Exactly.
Okay, so we know what they are, who gets them, what symptoms they cause, and how to investigate. Now for the big one. Management. How do you treat them? The notes stress it's very individualized.
It really is. Depends on symptom severity, whether the patient wants future fertility, their age, overall health, lots of factors. And the first crucial point from the notes, if they're asymptomatic, causing no problems, often no treatment is needed. Just monitoring, watchful waiting.
But if there are symptoms, especially that heavy bleeding menorrhagia, the notes list several medical options first.
Yep. For managing heavy bleeding, the notes suggest things like the levonorgestrel intrauterine system, the LNGIUS, or merinocoil, as many know it. Also, NSAIDs, like mefenamic acid, tranexamic acid to reduce bleeding, the combined contraceptive pill, or other progestogens, these aim to control the symptoms.
And what about treatments to actually shrink or remove the fibroids?
Medically, the notes list GnRH agonists. These create a temporary menopausal state which shrinks the fibroids by cutting off the estrogen supply. Ulipristal acetate is also mentioned, but with that important caution about liver toxicity concerns, currently not recommended routinely because of that.
Okay. And then the surgical or procedural options.
These are often more definitive. Myomectomy is the surgical removal of just the fibroids, leaving the uterus. That's the key option for preserving fertility or keeping the uterus. It can be done via an open abdominal incision, laparoscopically, keyhole surgery, or hysteroscopically, going through the cervix, depending on the fibroid's location and size.
And if fertility isn't desired or the fibroids are really extensive?
Then hysterectomy removal of the uterus is a major option. That can also be done in different ways. Total, vaginal, laparoscopic.
The notes also mention less invasive approaches, like uterine artery embolization, UAE.
Yes, UAE works by blocking the blood supply to the fibroids, causing them to shrink. But, as your notes rightly point out, there's still some uncertainty about the long-term effects on fertility and pregnancy outcomes. That's a key counseling point.
Right, and MRI-guided focused ultrasound is another minimally invasive option listed.
Correct. Uses focused ultrasound waves guided by MRI to heat and destroy fibroid tissue. Notes mention rapid recovery, but that long-term data is still emerging. There are also mentions of other drugs like danazol or mifepristone and procedures like endometrial ablation for bleeding, showing the breadth of options depending on the specific clinical scenario.
Got it. So finally, looking ahead, prognosis and complications. How does it usually turn out?
Generally, the prognosis is good. Your notes emphasize they are benign and treatable. And critically, they tend to regress after menopause, so symptoms often naturally improve or disappear then.
That's positive. But there are potential complications listed too. What are the key ones to be aware of?
Many tie back directly to the symptoms. Iron deficiency anemia from heavy bleeding is probably the most common. Then those pressure symptoms, bladder frequency, urgency, constipation.
Any more acute problems?
Yes, the notes mention torsion of a pedunculated fibroid that stalk twisting cuts off blood supply, causing sudden severe pain. Also, rarely, ureteral obstruction leading to hydronephrosis, kidney swelling, if a fibroid blocks the tube from the kidney.
And there's a significant list related to pregnancy.
Very important. Increased risk of recurrent miscarriage, the baby being in an abnormal position, malpresentation, something called red degeneration, which is painful fibroid breakdown during pregnancy, often with fever and vomiting. Also, potential for restricted fetal growth, premature labor, heavy bleeding after birth, postpartum hemorrhage, and that kidney swelling, hydronephrosis again.
And infertility is listed too, specifically linked back to those submucosal ones again.
Exactly. And the notes also mention hyaline degeneration, a common type of fibroid breakdown, but it's usually asymptomatic.
Wow, okay. That was a really thorough journey through uterine fibroids, pulling directly from your notes. We've covered the basics, the types, remembering intramural, submucosal, subserosal is definitely high yield.
The causes, the risk factors, age, ethnicity, nulliparity, the symptoms, remembering menorrhagia, and pressure effects are common, but many are silent.
How to investigate ultrasound first, TVUS ideally, saline infusion for submucosal.
And that whole spectrum of management, from doing nothing to medical options for bleeding, GnRH agonists to shrink, through to myomectomy, hysterectomy, UAE.
This overview should really provide a solid foundation for tackling fibroid questions in revision. Connecting the complications back to the symptoms like anemia from bleeding, pressure on bladder bowel helps make it stick.
And remembering key details like only submucous fibroids clearly impacting fertility or the specific investigation for them, that's crucial.
So the bottom line, fibroids are super common, especially in some groups. They're benign, but can cause significant problems affecting quality of life and reproductive health. But importantly, there are lots of effective ways to manage them.
Which leaves us with a final thought for you to consider as you revise. Given just how prevalent fibroids are and their potential impact, particularly on bleeding and fertility, how might a better understanding change routine screening or how we approach management for women in certain age groups or demographics? Are we doing enough?
Thanks for sharing your notes and letting us take this deep dive with you. We really hope this helps you feel prepped and confident for your revision. And remember, if you're revising for the MSRA, do check out pastthemsra.com.
Yeah, and you can also find free resources over at freemsra.com.
Join us next time for another deep dive.